Okay, so you're doing the same things you've always done, maybe even a little more. You're watching what you eat, you're moving your body, and the weight is not coming off the way it used to. Or the scale says you weigh about the same, but your clothes feel different, or they fit different. Your belly feels different, your energy is different, and no one has given you a straight answer about why. So I want to be clear about something before we go any further. It's not a willpower problem. This is not laziness. This is not just aging. What is happening has a name and it has a biological explanation. And once you understand it, the path forward starts to make a lot more sense. So let's talk about it. I'm Dr. Lola Ashaye. I'm a board certified family medicine physician and founder of InTouch Primary Care in Sugar Land, Texas, where I help people understand what's actually happening in their bodies from everyday health and prevention to hormones, perimenopause, menopause care, weight management, and so much more. And on this channel, my goal is to give clear evidence-based information so that you can have a better conversation about this with your own doctor and make more informed decisions about your health. Remember, this is general medical education, not personalized advice. Always walk with your own doctor about what's right for you for your specific situation. So let's get into it. So in the last episode, we talked about why lowering your weight and why some people are losing weight but are feeling weaker, and how that can be a sign that your body is missing muscle, protein, or proper monitoring. And today we're going to go one step deeper because for many women, especially women in their late 30s to 50s, the reason weight loss feels harder is not just calories, it's hormones, it's sleep, it's insulin resistance, it's body composition, all changing at the same time. So let's call, a patient I have, let's call her Sandra. Sandra is in her early 40s and she came in for her physical. So her labs were normal, everything looked fine, but she had gained about 12 pounds over the last 2 years and she hadn't changed anything. She was eating, in fact, she was trying to eat even better. Her belly felt rounder. She was waking up about 2 or 3 every morning and couldn't get back to sleep. And so she was tired, and then she was really frustrated about this. She was like, you know what? It feels like my body doesn't even belong to me anymore. And I hear some version of the story regularly. And the most important thing I could tell Sandra, and what I'm going to share with you today. And that is labs being normal does not mean nothing is happening. It means that the standard tests do not capture what is actually changing. Her body was in the middle of a major hormonal transition, and she hadn't yet connected the dots. So that's what we're going to do today. So it's important to know that the scale may not tell the whole story, but your body composition might be changing significantly. So one of the most disorienting thing about perimenopause is that the weight on the scale can stay relatively stable while the body is still changing underneath. Research on menopause transition show that women tend to gain more abdominal and visceral fat while losing lean mass, even when the total weight does not shift dramatically. So abdominal fat has been shown to increase at a significantly faster rate um, and increase at a significant faster rate during the menopause transition. Visceral fat, which is the fat around the internal organ, also rises. So the scale can actually be misleading because you may be losing muscle and gaining internal fat at the same time, and you will never know from the number alone. And that is why in my practice, I just don't look at a patient's weight when they describe these changes. I look at the body composition, waist circumference, metabolic labs, sleep and hormones. The full picture really matters. The other thing to understand is that estrogen does far more than regulate periods. So here is the connection that changes everything. Estrogen is not just a reproductive hormone. As estrogen levels begin to decline during perimenopause, it actually affects the whole metabolic system. Estrogen influences how the body handles blood sugar, insulin. It affects where the fat gets stored. It plays a role in muscle maintenance. It influences sleep quality, appetite signals, cholesterol, inflammation. It affects energy levels in ways that are real and measurable. So When estrogen starts to shift erratically in perimenopause and when it begins to decline in, as people get to menopause and postmenopause, a woman is not just losing a reproductive hormone, she's experiencing a metabolic shift. And that shift has downstream effects on her weight, her energy, her sleep, her long-term health. Understanding these changes is what we're going to talk about because people start to think, what am I doing wrong? What has changed? What does my body need now? And that's what we're going to talk about. But I want to talk about belly fat in midlife because it's not just a cosmetic issue, it's actually important. The shift towards abdominal fat storage during perimenopause is not simply about appearance, like getting a six pack, right? Visceral fat, which is the fat that accumulates deep in the abdomen around the organs, is metabolically active. It is more strongly associated with insulin resistance, systemic inflammation, changes in cholesterol, increased heart risk, type 2 diabetes than when fat is stored anywhere else in the body. So visceral fat is important to, look out for. So addressing belly fat in midlife is a prevention conversation. It's not just about vanity. And it's one of the reasons I take, body composition changes seriously, even when standard labs look normal. The other thing to understand is sleep disruption is one of the most underestimated drivers of weight changes in perimenopause. So research suggests that 40 to 60% of perimenopause women experience sleep disturbance, most commonly from hot flashes and night sweats that interrupt sleep cycles. And the metabolic consequences of disrupted sleep are significant. Poor sleep raises cortisol, worsens insulin resistance, increases hunger hormones, drives cravings, particularly for sugar and processed carbs. It also reduces willpower and cognitive clarity that supports good food choices throughout the day. So sleep is not a lifestyle bonus. Sleep is a metabolic intervention. So when I'm working with a woman in perimenopause who is struggling with weight, sleep is one of the first things I ask about because if sleep is disrupted, the entire weight management picture is working against her even before she gets started. So the other thing to understand is about insulin resistance because insulin resistance can begin years before blood sugar looks abnormal. And this is one of the most important normal labs teaching points in all of midlife medicine. So a woman can have a normal fasting glucose and a normal A1C and still be developing meaningful insulin resistance. With estrogen declining, the estrogen decline of perimenopause is directly linked to worsening insulin sensitivity. That means that the body is producing more insulin to do the same job, which promotes fat storage, especially in the abdomen, and makes weight loss harder to achieve and sustain. And standard lab panels do not always catch this early. It can take years for insulin resistance to show up as an abnormal glucose or A1C. This is one of the reasons I look more broadly at metabolic markers when I'm evaluating a woman in transition, not just the basic glucose number. The other point is that alcohol can be affecting a body differently now, and that's important to know. So this is a practical point that surprises a lot of women. That glass of wine that never used to bother you may now be affecting your sleep. It can affect hot flashes. It can affect cravings. It can affect your belly fat. So in perimenopause, alcohol can worsen sleep quality. It can increase cortisol disruption overnight. It can exacerbate hot flashes and night sweats and contribute to insulin resistance and abdominal fat. So it's not just about entirely eliminating alcohol, but it's about recognizing that your body's tolerance and response can genuinely change in midlife. And that if sleep and weight are already a challenge, alcohol may be quietly making both harder to manage. So hormone therapy is not a weight loss drug, though. It's very effective, and it matters, but this question comes up regularly, so it's worth addressing directly. Hormone therapy, when appropriate for the right person, is not a weight loss medication, and it should not be framed that way. But for some women, it may improve the symptoms that are indirectly driving weight and metabolic struggles, like hot flashes and disrupted sleep, night sweats, and some of those hormonal shifts that affect insulin sensitivity and body composition. Research suggests hormone therapy may have a favorable influence on body composition, insulin sensitivity, visceral fat in appropriate candidates. Whether someone is a candidate for hormone therapy is obviously no one's clinical decision, which you have to talk to a physician that knows you and knows your full medical history. But it's definitely a conversation worth having, not dismissing. So it would help to help the foundation, but it's not going to necessarily lower your weight using hormone therapy. So strength training is very important in midlife. We talked about this extensively in the last episode, and it connects directly here because hormonal changes of perimenopause accelerate changes in muscle mass and fat distribution. Estrogen plays a role in muscle maintenance, so its decline can mean muscle is harder to build and easier to lose. Research supports resistance training as effective for increasing functional muscle mass, reducing fat mass in sessions of strength training per week. So 2 or 3 sessions of strength training per week remains the practical target. So in midlife, strength training is not just about toning, it's about protecting metabolism, bones, balance, blood sugar, and long-term independence. So I know we've said a lot. So if you have gotten a lot from this, if explaining these things and walking through all of this has helped, and if you know another woman in her 40s, 50s who has been frustrated, confused about her body, maybe even blaming herself, please share this video with her. Understanding what is actually happening is the first step towards a plan that actually works. So if this has been helpful, go ahead and subscribe so you don't miss the next episode and share. So remember, there are many different things we've talked about. We've talked about the fact that the scale may not be telling the whole story. You need to understand what your body composition is made up of. That full picture matters. Estrogen does far more than regulate periods. When estrogen shifts, it affects a lot. Belly fat in midlife is not just a cosmetic issue, it's an actual metabolic issue that needs to be addressed. Sleep disruption is underestimated because it can really affect many factors that affect weight management in midlife. Insulin resistance can begin years before it shows up on standard labs, and it's important to be addressed. Alcohol needs to be addressed as well because it might be quietly making it harder to lower weight and also affect sleep. Hormone therapy is not a weight loss drug, but it matters a lot, and it's important to have that conversation. And strength training is very, very important in midlife. So if you've heard my labs are normal, so nothing can be wrong, well, remember that standard labs capture a snapshot. They do not always reflect early metabolic change, insulin resistance in its early changes, or body composition shifts. Normal labs, that's good news, but they're not the full story. So if you're experiencing significant changes in energy, sleep, weight distribution, or how your body feels, those symptoms are worth investigating beyond a basic lab panel. Sometimes people think it's just aging, there's nothing that can be done. Well, the changes of perimenopause are real and biological, but they're not a wall. They're a shift in conditions that calls for a shift in approach. So women who adjust their strategies, so more protein, more strength training, prioritizing sleep, metabolic monitoring, and in some cases, hormonal support, they would progress. They'll get good results. So the goal is not to fight aging, is to understand it and work with it. So some people feel like, oh, I just need to eat less and move more. That framework works when the metabolism is functioning the same way it did at 32. But in perimenopause, that equation has changed. So eating too little can actually accelerate muscle loss. It can worsen fatigue, can increase cortisol. Moving more without strength training does not protect lean mass. The strategy needs to match biology, which is why a plan built around your current body, not the body you had 10 years ago, needs to get needs and is needed so that you can get, better results. So hormone therapy doesn't fix everything. It's not that simple. Hormone therapy may be part of the picture for the right person, but it's one tool. It requires a full clinical evaluation. It's not appropriate for everyone. It does not operate like a weight loss drug. And the decision involves more than just symptom relief. That conversation, it's one you should have with your doctor. So if what you've heard today sounds like your experience, the sleep disruption, the belly fat, the normal labs that do not explain how you feel, the most useful thing you can do is bring this conversation to your own physician. Ask specifically about perimenopause, body composition, metabolic macros, and sleep. Ask whether a more comprehensive evaluation makes sense for where you are right now. And if you're in the Sugar Land area and you're looking for a physician who approaches midlife health this way, looking at the full picture, not just the standard panel, at InTouch Primary Care, we offer a complimentary 15-minute meet and greet. The link is below. And wherever you are, the right questions asked to the right doctor can change the entire direction of this conversation. So imagine if instead of pushing harder at a plan that no longer matches your biology, you had a clear explanation for what has changed. You have a strategy built around your body right now, not more restriction, not more guilt, just a smarter plan that accounts for your hormones, your sleep, your muscle, your metabolism. That clarity is available, and it starts with understanding what's actually happening in your body, which is exactly what we talked about today. And next week, we're going to be making this more practical. So we've talked about medications, we've talked about muscles, we've talked about the menopause transition. And next week, I'm going to share 2 simple habits that can help weight management actually stick without another extreme diet. And I will see you then.